Afternoon and welcome to our Monday lunch live stream entitled COVID-19 and Cancer in Victoria, Approaches to Advance Care Planning and Important Conversations. My name is Genni Newnham and I'm the Chair of Palliative Medicine at the University of Melbourne, St Vincent's Hospital, and in collaboration with the VCCC. The VCCC is proud to partner with Monash Partners Comprehensive Cancer Consortium, MPCCC, to present this, our special COVID-19 edition of Monday Lunch Live. So COVID has thrown out so many challenges for us involved in cancer care, and some of these are new, such as navigating telehealth and all these sorts of meetings. And some of them are old challenges but repackaged. And one of these is in the area of communication. Communication in all aspects of cancer care has probably taken on a slightly new dimension or a new edge. We're always involved in delivering results or developing treatment plans or navigating or perhaps ceasing treatments. But the differences that COVID throws up in this space are many. There's new and different risks, there's uncertainty, and not the least having to have some of these conversations by screen rather than face-to-face. So today seemed a good opportunity to revisit some of these conversations and to think about them in our new context. But before I begin, I want to acknowledge the traditional custodians of the land on which the VCCC is located and pay my respects to the elders, past and present, of the Kulin Nation, and extend that respect to other Indigenous Australians present online. The Victorian COVID-19 Cancer Network has been developed or established in a response to the challenges that are involved in management of cancer amid this global health crisis. It's a joint initiative of the VCCC and the Monash partners and aims to provide support and advice and resources and a forum for discussing all sorts of things for health services and clinicians treating people with cancer during the COVID-19 pandemic. I would really encourage you to hop on and have a look and perhaps join up to this forum, and membership is open to all of you. There are also a series of upcoming events that we have. As you would know, the Monday Lunch Live is consistent with all of the COVID-19 recommendations being undertaken by webinar until further notice. And there's a series of online events that are coming up which I think you might find interesting. And so please register your interest at the VCCC website. There's also a Learn page if you want to have a look at some of the previous topics. Now today, the forum is going to be a group of experts who are joining me, people in the field who are very highly experienced and who I'll introduce as the session unfolds. We will have a format of a short video, which will be followed by a couple of presentations and then a panel discussion. And the panel discussion will be one where we're actually trying to road test some of these communication conversations that we might find challenging. And I guess this really brings me up to the notion that we would encourage you throughout the webinar to ask questions. We're interested if you have particular questions, or I guess in particular statements or phrases or situations involved in communication with people with cancer that you might find particularly challenging. Send them in, and you can do so via this GoToWebinar platform on your laptop or mobile device. And do this throughout the presentation, and we will aim as part of our panel discussion to perhaps address some of your questions or try to, as I said, road test some different responses that might be ways that we could think through responding to such a statement or such a phrase or such a challenge. So just to set the scene, we're going to begin by introducing or by having a brief video. This is one that's been developed, I guess, to really alert the public around the whole importance of advanced care planning discussions. It will take just a moment to load, so please be patient with me. The video is just a couple of minutes long.
Life is full of moments when it's important to be open, to be ready, and to be heard. This is especially true when it's time to consider advanced care planning. To help, here's how you can plan for tomorrow so you can live for today. Be open to thinking about your beliefs and preferences for care. This includes thinking about what you value most and the treatments you would choose to have or not have. Most importantly, you'll need to think of who you would trust to make these decisions for you. Be ready to talk about your beliefs and preferences for care with your loved ones, your healthcare professionals, and make sure they understand the way you see things. Ask questions if anything is uncertain, and try to consider what they might need to know about you to make decisions later. Be ready to make choices. Starting with the appointment of your substitute decision maker. They'll need to be over 18, as well as someone who listens carefully and understands your preferences. Either way, it needs to be someone you trust to make decisions on your behalf. Be heard by documenting and sharing your plan. First, write it down so that if others need to make decisions for you, they'll know what you would have wanted. Share your plan with your loved ones, your substitute decision maker, and the healthcare professionals responsible for your care. This way, everyone's on the same page. It may be difficult, but it makes sense to plan for tomorrow so you can live for today. Be open, be ready, be heard. To make your plan, visit our website or call for advice and support.
Thank you. I'd now like to introduce our first presenter, which is Linda Nolte. Linda is Advance Care Planning Australia Program Director. She's passionate about patient-centred care and improving healthcare, and has more than 20 years' experience of working in oncology, aged care, community health, and across a number of clinical governance and government sectors. More recently, she managed the Australian Cancer Survivorship Centre, and today Linda will present on advanced care planning priorities and actions. Thank you, Linda.
Thank you very much for having me join this webinar. I appreciate the invitation, and I'm really excited that there's so much interest in advanced care planning. So yes, I did have the pleasure of working in cancer care and in cancer clinical governance and policy for some time, but I moved into a role as the Director of Advanced Care Planning Australia, which is still, of course, a topic that's extremely relevant to cancer patients and, very important in terms of extending patient-centred care. So it's always important to know, what is advanced care planning and, what's advanced care planning? And the video has given you some insight into that, but it's certainly a process that's a coordinated process of communication and of planning for a future time when somebody loses capacity to make those decisions themselves. So people have the ability to think and share about what their values, their preferences, what future treatment decisions they would like, and to ensure that they get appropriate care, whether it be at end of life or whether it be just during their treatment at a time when they might lose decision-making capacity. It's really a person-led process. That's the real difference between it and something like goals of care or medical-driven orders. So the person does define what their goals and their preferences are, and they can document them or otherwise at least share through conversations with their treating team or with their loved ones about their preferences. You have to have decision-making capacity to do advanced care planning, and the time when it comes into effect is when the person loses decision-making capacity. So why is it important? Well, we know that it's a human right to be able to, to consent for medical procedures or otherwise to withdraw or refuse those procedures. So it's certainly built into just the human rights of people being able to have this personal autonomy and self-determination. It certainly promotes care coordination because their preferences are made known, and it can inform what their future care would look like and really help to make that process a lot easier and clearer from the outset. It can be, change over time, of course, depending on what somebody's clinical situation is. And so updating any advanced care planning documentation regularly is going to be really important. Through studies, there's clear known benefits for the person, for the loved ones, and also for treating teams. And there's clear evidence that people are more likely to receive the care according to their preferences if they have a directive in place. But during COVID, there's certainly been a lot of talk around uncertainty around resource allocation, or we know that in future, since there's a lot less diagnosis occurring at the moment, that there is actually going to be higher service demand in future and more people may experience advanced cancer. So it will be a really important part of that response, ensuring that we understand what care people want and, allocating services accordingly. So advanced care planning is important enough that there's actually dedicated legislation to support it. In Victoria, there's the Medical Treatment Planning and Decisions Act, and that allows to inform how medical treatment decisions and consent should occur at a time when somebody loses their capacity to make those decisions themselves. It provides for people doing an advanced care directive, whether that be a values directive or a directive about instructional preferences, or also appointing one or more substitute decision makers as well as a part of that process. So the law is really about extending, what we know in cancer is really important around person-centred care. It's about extending it through to a time when people lose capacity. And there are other laws dealing with loss of capacity, whether that be the Guardianship or an Administration Act or Mental Health Act. So in this case, this law is dealing with people that may be losing capacity, that otherwise had capacity, but something has happened to them. And most commonly in cancer care, that might be something like delirium, changes in cognitive status, they're reaching their end of life care phase, and that they need more support around decision making, and these directives can inform it. There's policy as well as law that supports the importance of advanced care planning, and there's the Australian Health Sector Emergency Response Plan that specifies the importance of advanced care directives and their increased uptake. But in cancer care, their advanced care planning and the use of advanced care directives is outlined in the optimal care pathway. So despite knowing that we have law and that we have policy, that there's no benefits to consumers and to the health system if people do advanced care planning, until recently there was actually little known about what the uptake looked like in Australia. So Advanced Care Planning Australia has done some prevalence studies across a number of sectors and sites, and we're very pleased that many of the Victorian cancer services did participate in data collection. And so this slide tells you about the prevalence. And unfortunately, the prevalence and uptake of this form of planning is quite low. So overall, nationally, we looked at 4,187 health records of older Australians that were 65 years plus. They were either in general practice, or they were in a hospital environment, or they were in residential aged care. And we found that only 25% had any form of documentation in place. So then when we looked more closely at the cancer cohort, we were surprised and I suppose interested to find that the prevalence was actually lower amongst that group. So only nationally, 15% of people that had a cancer diagnosis had any form of advanced care directive in place. And particularly being an older group and population, we were quite concerned that these results are so low when people are more likely to be needing to make end-of-life decisions. So in Victoria specifically, our study showed that there was only a 13% prevalence, and only 3% of these were the appointment of a substitute decision maker. So when we think about the importance of that role and perhaps their need to be involved in consent, it's very low result to have found. So trying to understand it further, we wanted to look at, what are the attitudes, what are people's perspectives, so consumers as well as health professionals in relation to advanced care planning. And this slide just outlines some of the results that we've found. We've done national surveys. We're in the process of publishing this data, so I'm just providing some of the high-level findings to you. But generally, we found that there was a proportion of the population that have actually heard about advanced care planning, but we certainly could improve on that. So only 49% had heard of advanced care planning. Most people had preferences that they would like to have in place for, these types of decisions, but yet many of them hadn't spoken to their doctor or their treating team about that. They were more likely to speak to their family members. So it's important then that we involve family in these discussions. They have a role as the substitute decision maker, or in the Victorian legislation, they could also be appointed to be a support person to, help with their care. So certainly, this provides us with valuable information that we not only need to get to the consumer, but to their support people as well. Then we did a national survey of oncology professionals, and, the results, of course, are a bit on the lower side, that only 53% reported that they had a good knowledge and understanding of the legal frameworks or the law related to substitute decision making, and that really there was a lack of expertise in discussing advanced care planning. So it makes it well placed for this webinar to provide some further advice around how to have these important discussions. So what we would say are the priorities then, I suppose, considering the COVID environment, and, that we want to make sure that advanced care planning is seen as important to everyone, all adults. In Victoria, it is relevant to children as well. It's the only state that considers it for children. And that really we're trying to increase people's understanding and how they conceptualise advanced care planning and what's relevant to them. So we provide them with resources, and we're promoting the uptake. In cancer care, it's even more so important that people are doing advanced care planning. So this just provides some of the high-level steps of what could be done. So we could be capturing who the medical treatment decision maker is, so the substitute decision maker on admission, and whether or not they have an Advance Care Directive could be placed into the system. We could be promoting that health professionals are involved in these discussions, and really it's no one person or one professional's responsibility, since advanced care planning is really embedded in self-determination, autonomy, choice, person-centred care, rights. We would all agree that this is a multidisciplinary approach that's required to a good advanced care planning in cancer care. So once we have documents, if they are in place, we need to make sure that they're stored, transferred and accessed appropriately, and so that it can be available at the point of care. And really the main role is to inform medical treatment decision making and making sure that those decisions line up with what the person actually wanted. In the final stages, if somebody is just 12 months out to their end of life, a further detailed advanced care planning discussion is very valuable, and that's what we'll talk about more today. But certainly there can be use of other documents, and such as goals of care or medical-driven orders, which are often done in collaboration with the person, but may be documented by a health practitioner rather than the person themselves. So we have a range of resources on our website that's available to support increased advanced care planning in cancer care. We have a phone line. We've done a lot of work recently with the cancer councils, and we're really pleased that their helpline can answer a series of questions as well. There is a learning hub and a range of resources available. So thank you very much.
Thank you, Linda. Thank you for your presentation. We might move on now to our second speaker, and I'd like to introduce Professor Peter Martin. Peter's an old friend of mine, and he's also Professor of Clinical Communication and End-of-Life Care within Deakin University School of Medicine. He's the inaugural director of the Deakin Centre for Organisational Change in Person-Centred Healthcare. He's been a clinician in palliative care for some years and has been involved just as long, over 25 years, in teaching communication skills across universities and indeed across nations, across countries. He's taught at numerous postgraduate courses and to a variety of clinical care settings, including surgery, intensive care, ED, oncology, palliative care, and more. And today, Peter will present on communication skills to to employ when discussing Advance Care Directives. As along partnered with the Cancer Council for the past few years and run some 3-day intensive workshops in communication skills, which is very much a sort of an embedded experiential type model of teaching and very interesting. But anyway, I think we're off and running. Thanks, Peter.
Thanks, Jenny. Apologies about the tech. So I'm just going to focus on a slightly different thing, which is kind of the broader conversations that underpin prognosis, communicating risk, values and goals, and all lead to good advanced care directives. I can go to the next slide, please. I've got my Twitter handles on there, which you can look for later. I'm not sure what's, there we go. Thank you. So I'm just going to have a go at looking at some key articles and what we could learn from those, and then aligning them to some key skills. So the first thing I want to say, here's a paper from last year, actually done by a young resident doctor, who looked at what happened for people with metastatic cancer, what happened when you did early goals of care discussions. And the first thing I want to say, their data wasn't as good as Victoria's, Linda, that only 3% of people had a goals of care discussion of any description before they come into hospital. And of course, one of the things that sometimes people say about this is that bringing up this topic is very stressful, but in fact, this study showed that almost 90% of patients did not find the discussion stressful. When you go across and actually see what the impact of these discussions were, they were inversely associated with a critical care admission. I guess the point here is that these discussions actually do change what happens to people's care. And that the early, as you see here, less than 2 days goals of care discussion meant that they had a dramatic reduction in their 90-day hospital readmission rate, over 80%. I mean, it's phenomenal when you think such an intervention could do that. And of course, their stay in hospital also shortened, as you see down the bottom there. Next slide, please. Now, the point of this little article is that when do people bring this up? When do they get it? When do you as a clinicians get a chance to discuss all these issues? Well, there's a lot of evidence about sharing the agenda. And what I'm going to do here is you'll see these colored call-outs. I'm going to show kind of the summary of the article, but what skills that means for us as clinicians. And what they found was that if you said, what would you like to discuss in the consultation today at the start of the consultation, and then you pause, that is when people tend to say, can you talk to me about the future doctor or nurse or whoever you are? Okay, so there's this key skills that if you can ask about their agenda right at the start or very early after you've built some rapport, then if you pause, that's when they tend to bring up this big question for them. So the key skills are ask them at the start, go slowly, and wait for a pause. And I'll talk a little bit more about pausing later on. Next slide, please. Why is this important? I think Linda's touched on this, but first of all, here's a paper that showed that 55% of people with advanced cancer actually thought they were curable. And I'm going to come back to this because when myself and colleagues have run lots of workshops, there's a couple of key steps that tend to be where most of us as clinicians go wrong. And as you can see here on this study, they also found that there are certain cohorts of our community that are particularly prone to having an inaccurate perception. So if I go to the skills, then I would say the two biggest skills you remember when you're having any of these discussions is to gather information before you say anything. And so gather before you give. And if you think of Walter Beale's SPIKES acronym, which has been around since the 80s, and in fact, one of our colleagues from Sydney did another one, the key bit is checking perception with the patient in depth first before you say anything, because that's where it goes wrong. That's where you find out this gap between the reality of what we know and what they have perceived, given the frequency of this kind of misperception. So what you need to do is gather a little chunk of information and then check it. Watch for cues, because often they're giving off, especially non-verbal cues. That's what the NV is there. And this technique of teach back, which is getting them to recall what you have said so that you're both on the same page. We know that aids recall and understanding as well. And again, I can't emphasize this enough. Go really slowly. The evidence of how long you have to pause is pretty clear. It's just 3 to 5 seconds. So just remembering your hand, just counting out. That's when, and we know that then people are about 50% more likely to say important things to you that you can clarify. And lastly, be explicit. Don't use any minimizers of a little bit or quite or any of those sorts of things. So be very explicit, and of course, don't use euphemisms. Next slide, thanks. So here's 2 other studies, okay? The first thing I want to say is that, do people want these? And we could have put up numerous studies, but only 50% or 53% of people who wanted a prognostic discussion actually got one. It even further drops off further. Only 30% of people who wanted a broad end of life discussion got one, and only 25% of people who want to discuss what palliative care might offer in their care got one. So we tend to avoid some of this for a whole variety of reasons. And you can see on the right-hand paper then, this idea of what's the thought in this case of an oncologist versus a clinician. So the patient, and nearly 70% of the time they're discordant about what they think. Okay, 90% of the times the patient does not realize that they have a very different view of the future than their specialist, in this case an oncologist. And look at this, 96% of the time the patient were much more optimistic about the future. So when you're giving this sort of use, you need to use signposts. I need to discuss something about your scan or your blood test, or it could even be your blood sugars or whatever it happens to be, and then pause. Often this evokes, emotions. This is a tool called NURSE, but there are numerous ways you can support people and attend to their emotions, because if they're emotionally aroused, they're not going to be able to respond. And then lastly, I love this quote that I saw on Twitter recently: don't respond to feelings with facts. Most of us rush in to fix, and I think it'd be 2 F's in there. In fact, fix it or fact it. And actually, most of the time, what people, when they're voicing fear, concern, worry, uncertainty, is they want to hear that you've got that and acknowledge it. So remember that little catchphrase: don't respond to feelings with facts. Attend to it first and then provide the information. Next slide, thank you. There's an even bigger discordance, particularly about end-of-life preferences for people who don't know the prognosis. So these are all key steps to make the right decision. So the first thing is that 40% of people only knew, increasing, they don't know their prognosis. And if you look at this cohort with stage 4 cancer, this relates to a whole pile of things that most of us would agree that in general is not appropriate in their last 2 weeks of life, last month of life, including hospital admissions, intensive care. And so you're more likely to get aggressive treatment if you don't have the end of life conversations, and you're more likely to get PAL care if you do. Now, you may not be aware of all the different question styles that are in the healthcare communication literature, but hypothetical inquiry is a key one. And that's this idea of, if you were to get COVID and then a week later we get really sick, can we talk about what's really important to you? Can we talk about what would be some of the things that you'd be concerned about, what your worries are, etc. So hypothetical inquiry is taking them to a hypothetical place to help discussion. And it's a key questioning skill that you would need to utilize in this sort of situation. The other skills that have been in the literature, and there's good publications around this, are using things like best, worst, and likely scenarios. And lastly, about how to help to frame these. So you can say, this is what I think is the best, this is what I think is the worst, and in your case, this is what I think is likely. I just want to talk about this idea of hope and how concerning it is to clinicians about destroying hope. And here you can see this histogram about a hope index, a kind of validated tool, about before they got prognostic information and after. And you can see if they're the same. And in fact, when you look at the complaint literature, having run a class with some colleagues about this recently, most of the complaints are not about what information was given, it's all about how. So it's those core process skills about how we talk to our patients, and they are complex skills that require us to practice. So I would encourage you to ask patients not only about their hopes, but their fears. be aware of fixing, and explicitly show them that you have heard what's important to them by summarizing periodically and being very explicit in your empathy. So honest disclosure done skillfully does not destroy hope. I think it's last slide, if I remember correctly. So this is from Harvard, and what I want to just say to you is that this is a relatively short intervention at the Harvard Serious Illness Group. Look at the impact for the patients in terms of anxiety, depression, how many conversations were had, what they were about, look at prognosis and illness, about life-sustaining treatments. They happened a couple of months earlier, and they were much better documented. This is all about giving people a chance to find their own words and have skilled conversation. So would that be funded if it was a drug? I reckon it would. So last slide, I think that's my time. So I'm sorry I've gone a little bit over time with some of the technical glitches, so I'm just going to hand back to Genni.
Thank you, Peter. Thank you very much. And I've asked you to stay on the webcam, Peter. And I'd like to welcome back Linda and also to introduce our other two panel members, Dr. Genni Newnham and Dr. Alexandra Clinch, who are in a moment going to join us. And whilst they're coming on screen, I will tell you a little bit about them. So Genni is a medical oncologist practicing at St Vincent's Hospital, Melbourne. She has particular interest in patient-centred care and patient experience outcomes. And in addition to her oncology work, Genni is actively involved in medical teaching at a whole lot of levels and is also the supervisor of the pre-vocational training program at St Vincent's Hospital. So welcome, Genni. And Alex is the Deputy Director of Palliative Care for the Royal Melbourne Hospital and Peter MacCallum Cancer Centre. Alex has wide clinical experience in palliative care practice and a passion and enthusiasm for clinical teaching and communication skills training. So welcome, Alex.
Thank you, Genni.
So today our panel is going to be a little bit different, and we think that this is because it's particularly important that we, I guess, model what we're talking about. So it's not only important to hear about and recognise what skills are available, but also quite helpful to see them being enacted, to see some of the language that's used. And often, particularly I find that when I'm doing these sorts of sessions, I hear phrases that I think, wow, that's really neat. I think I might sort of see if I can use that in my practice. So I'm going to put a series of scenarios and some questions and statements to our panellists who will respond and also try to articulate the communication skills or tools that are being used as part of this. At times I will be the patient or the person with cancer, so forgive my acting skills, but you'll have to roll with the punches on this. And I might start, and sorry, as we're going, I would encourage you to put any questions, or particularly if you've had, there are particular communication scenarios that you find more difficult, and perhaps we can try to think about how one might respond and try a few different responses to that. So I'm going to open up by starting with Genni. So Genni, you are seeing a woman called Andrea who has metastatic colorectal cancer, and she's on second-line systemic treatment. And you're seeing her in the consultation today, and you're wanting to introduce the notion of setting up broad goals of care and particularly an advanced care planning discussion. I wonder if you could tell me what things go through your mind, what things you're thinking of when you're approaching this sort of consultation.
Thanks, Jen. So I guess I think it's probably important to make a distinction that if these are patients that we are seeing on an ongoing basis, we have the advantage of establishing a trusting relationship and good rapport from the outset. And I find that in spending due time in my early consultations, and then maybe at other times when we're talking about a change of treatment or other significant stages in care, it can be really useful in making sure that we're avoiding misconceptions or differences in my view of what we're trying to achieve as opposed to the patient. And I think that spending that time early on then makes conversations like this one we're trying to have now easier, because it's really just an extension of a number of conversations we've had along a timeline of treatment. I think if these conversations are needing to be had by people who don't know the patient, so if the patient turns up in emergency or is admitted and there are different staff looking after them, it is much more difficult for those conversations to be had by people who don't have a relationship with the patient, don't know the patient's understanding of where things are at. So that, I guess, is just a general overarching principle that I would try and maintain with most of my patients if I can. But then in setting up on the day, I would be thinking of how I'm going to work this into our usual consultation, having a think about whether I think she would benefit from having a support person or family present. I find there's a lot of variability. Some patients actually better at having honest conversations about these sort of things in the absence of their family members, where they don't feel they need to protect anyone and they can speak very clearly about what they're worried about, what they do and don't want. Whereas others, I think, would be better served by having support from a family member. And then obviously I'd want to make sure I had sufficient time so that it could be a constructive conversation, not rushed.
So how would you open it, Genni? How would you introduce it? What phrase might you use?
That it's a patient that I'm saying I know and we're fairly comfortable with each other. I would probably get through the usual business of the consultation about, your treatment and your side effects and what we're going to do this time. And then I would probably lead with something like, so there's something else that's important that we haven't discussed much before that I'd really like to start having a talk about with you, if that's okay. And with a little pause, and then I would follow with, have you had any thoughts about what you maybe would and would not want to happen if you were to become extremely unwell at any stage and maybe couldn't make decisions for yourself? How I would open, and then...
Yeah.
Oh, well, I guess if I am trying to predict what might happen from there, I guess I would categorise the responses that I get often into 3 categories. The easy one is a patient who said, oh, yes, we've been talking about that and I definitely want this, this and this, and I don't want that. I guess less often I would have a patient that says, oh my goodness, that's far too scary, I don't ever want to talk about that. But most people would probably say, what do you mean?
So what do you mean?
So then I would lead in and I guess try and normalise it and say, well, it's really useful for me to understand what's important to you, so that if something happens in the future and you're not able to tell me what you would and would not like, I can be sure to make sure that we are still treating you in the way that is consistent with your wishes.
Okay, thanks, Jen. And just so we're sort of pulling out some of the skills that sort of Peter was highlighting before, do you want to have a go at saying what some of those were, and I'll chip in and add to that?
Yeah, sure. That's probably been the most difficult part of this whole exercise, is trying to think in a constructed way about what it is that I actually do. So I think in saying that I try to make sure people are really well informed and have lots of questions along the way, I'm really trying to deal with those inconsistencies between what I think is happening and what the patient might think is happening. But what I do is I do try and normalise it, and I'd like to use that hypothetical scenario to say, well, all's going well now, but what if something went really badly? Have you thought about what you'd want to do? And I emphasise that it's helpful for me and that it allows us to keep working as a team, having done that pre-planning.
Great. Can I add a couple to that as well? So I think you also asked permission to talk about it. So you sort of asked if this was okay. And I think you also said something about this is what we talk about with all our patients. So it's not you personally, it's just something that we do as part of good care. Thank you. That's terrific. So I might move on to Alex. Alex, I'm going to go to a different scenario, and I want to introduce John, who's a 72-year-old man with metastatic lung cancer. And you're going to see John, but you have heard from the other staff, from perhaps he's been having a chat to the nursing staff, that he is interested in finding out a bit more about his prognosis. And you think that this is going to come up in the consultation. I'm wondering what sort of things do you sort of think through or have in mind when you're having a prognosis discussion?
So I would think about who should actually be there with John when we have this conversation. His wife, or maybe another important support person, particularly more so if we're perhaps going to be talking about some bad news. I'd also be wanting to make sure that there is enough time for the conversation and also the privacy for it to occur in. And I'd also myself be a bit curious about what he might know already.
Okay, great. Thanks, Alex. So let's say you're in the consultation and John says to you, "So doctor, how long have I got?"
So John, that's a really important question, and it can be a hard one to ask. So thank you for having the courage to ask me that. I'm happy to talk about this with you now, but to start with, could you tell me what you understand already, John?
Okay, so I'll be John. So, well, when I was diagnosed back in November, the doctor told me then that it might be 12 months, but it depended on how I went with my treatment. And I was really good for a while. First treatment was great, but then stopped working, and now I'm on my second type, and I just thought maybe I should ask again.
Okay. And so that I can best answer your question, John, it would be helpful for me to understand a bit more about you. Can you tell me why this is important to you?
Well, obviously I want to know, but you know that my daughter's pregnant, and this will be our first grandchild, and she's due in September, and we're really excited, and I just want to hold her hand and hold that little baby.
Great, that sounds really important. Thanks for that, John. Time out.
Okay. So Alex, tell me what skills you were using when you were in that consultation.
So to start out with, I was sort of acknowledging the seriousness of this question for John, and also respecting his courage in asking that. And we know that respecting behaviours lead to sort of more positive emotional tones between clinician and patient, but also even fewer complaints in healthcare as well. I guess the next thing I checked was John's perception, as Peter's outlined, is really important to check up front, because that will probably inform the rest of the conversation. And then I guess I did some exploring as to actually why this is important for John.
Great, thank you. And so you're at a point where you'd be giving information now. What would be the way that you would frame it? How would you be thinking about that? Yeah,
so he's given me a timeline. So I do have to respond to that. And it would be, depending on his clinical information, if we were to say that perhaps it's not going to be good news, I would need to respond to that in a way, I guess that's quite clear and to the point, because the first thing that I say, the first sentence should be the thing that he takes away. So it might be, say, if we're worried that John's at a later stage of his illness, I might say, something like, from my knowledge of your situation and how your cancer has been changing, unfortunately, I think there's only a 50-50 chance that you'll still be around for your grandchild. So it's important to say quite clearly and in quite a short way the information that he needs to hear. Following that, I would pause. And that pause would be to see how John responds to that. And if it's not good news, then it might well be with emotion. And then responding to that emotion is important to do before we give further information. So it might be to say, I can see that this is not what you were hoping for, or I wish I had better news for you, something like that.
Thank you, Alex. Thank you very much. So a few questions coming in from the audience, but I might just go to our last scenario, well, another scenario that we prepared, and then we might go to the broader questions. So Peter, could I come to you, please? Peter, you're in charge of the care of a woman called Roma, who's 84, who is a bit frail and lives with her daughter and son-in-law. She's got some mild heart failure and COPD, and more recently she's had an incidental lung cancer diagnosed. She's not to be having any treatment for that because of her frailty. She's now been admitted to the ward with the COVID-19 infection, and she's had discussions with you and your team, and the plan is for her to be cared for on the ward, and she's not for escalation to intensive care. But she'll be given best care on the ward, including, if need be, symptomatic care. But her daughter has arrived at the hospital, Jan. Jan's very angry. She's heard from the ward staff. The ward staff have heard from her, and she wants everything done. She wants to speak to the person in charge, and you've been called down to the ward to talk to Jan. Again, when a situation where someone is very angry, the sort of things that go through your mind approaching this consultation.
Thanks, Jen. Great scenario. So there's a few things that jump through my head immediately. First of all, anger is often when people feel disempowered, and that it's the only way they feel that they can grab some of that power back. So whilst at a human level, I think it feels like they're attacking you, the real thing is to stand back and often listening, empathizing, this technique of normalizing for the population. That, a lot of people coming into an unexpected event would be very worried and distressed, and may not feel that they're given the right information. So I think the majority of the time, using a range of techniques, there's not usually one silver bullet that's going to fix a daughter, kind of arriving into a very distressing situation like this. So that's the first thing. The other thing is a colleague has a lovely phrase where he says, "See anger, read fear," which is, underpinning a lot of this is often people being frightened about what may be ahead and really asking, so again, checking out what they know, responding to the emotions, checking in, and kind of using a range of techniques, being very careful about the non-verbal cues. So I think there's no one silver bullet, but I would suggest that rather than defending any of this, the first thing you want to do is empathize how hard it must be to come and be really worried about your elderly, frail mother in this situation. The everything done bit, I would really kind of, praise her kind of advocacy, that she wants to advocate for her mum, talk about what she's wanting to achieve, and then taking it back probably to her mum, Roma, and saying, what do you think Roma would want? What do you think Roma, tell me about Roma? So find out some of that kind of pre-morbid kind of context about how Roma has been, what's been happening maybe in terms of her function, her wishes, finding about her values, or her aspirations. So there's a whole pile of things I'd do before I'd address the everything done bit. I think the temptation is just to go straight to that because they're in your face. So I'll pause there. I mean, it's such an interesting thing. And what I would say to people is the evidence is that just like you need to practice any other skills, you need to practice these skills and kind of mock them up. So, this is tricky. And I just want to acknowledge that for clinicians, the reason that a lot of these conversations are maybe not had or avoided or handballed to the next person is that we all find them quite confronting. And they are complex skills, but we need to practice them like anybody else, and or watch a senior colleague who you really respect do them and learn from them. So I'll pause there.
Great, thanks, Peter. And without going through the whole scenario, I think that's a good spot, and thank you for setting us up for that. There's been, we might just pause the panel sort of scenarios that we were thinking through. There's been a few questions, and one question I'll throw to you, Linda, first. Someone's asked the difference between an Advance Care Directive and an Advance Care Plan. Would you mind just highlighting that, please?
Yeah, sure, thanks. And I actually just posted a response to some of the questions in the chat. Advanced care planning is the process of producing or having a discussion that may result in the production of an advanced care directive. Advanced care directive is the form that's recognised within law. Sometimes people use the term an advanced care plan, and it's just, I suppose, an informal term. It can be used, but it's not the most ideal term because really the law recognises an advanced care directive. A directive means that it'll have certain elements and formalities within that form so that it can clearly be identified as the person has written it. I mean, most of us know that we need to adhere to patient identification requirements. So, you know, you want to make sure it's got the person's name, address, date of birth, that it's been signed and dated. And so an advanced care directive is usually more formal and recognised with law. It's meant to be binding, and you know, from a doctor or a treating team's point of view, you're probably more likely to follow it than an informal advanced care plan.
Thank you, Linda. Maybe a question that's come from the audience, I'll throw maybe either to Genni or Alex, is how do you have these conversations when people's English isn't their first language? Or how hard is it to have these conversations, I guess? Or let me pull up the question exactly. How about if the patient doesn't speak English well, is the question.
I think the gold standard is that we use interpreters for every conversation we have with patients who don't speak English well. I guess that would be one way of trying to communicate more effectively. Sometimes for practical reasons, it ends up being family members who act as interpreters, which is not gold standard, and also carries with it that sort of emotional weight as well for a family member. So ideally we use interpreters if we can.
There's been a few questions. Sorry, Genni, did you want to add something?
No, I would just agree entirely. This is a conversation that I feel very strongly I would organise to have an interpreter present, and if I couldn't, I would make another time for the conversation with an experienced health interpreter.
And Peter, you're going to add?
Yeah, look, a few things. First of all, I often preface that by saying, so that you can listen to this information and be an advocate for your loved one, I don't want you to have to be translating. And so in a sense, what's in it for them? What's in it for them is they can listen, take notes, and not have to translate. Never mind the evidence that, you know, what they translate often is different. We know there's both, even professional interpreters, they tend to leave out empathic comments and go very factual. And the last thing is to empower the patient to say, you know, this is what I'm suggesting. How do you feel about that? If despite all that, I think there are some skills that become even more important, and that is to go even slower, pause even more, watch for the non-verbal cues that they're confused, and to summarize and to get them to repeat back so you can really check in that you're on the same page. So I think, you know, whilst the gold standard is what we'd all want, often that may not be available. There are still things you need to think in your skill set for those people with language issues.
And I think just probably time for our last question is really around training, and there's a few questions around training. One is, what is the evidence for effectiveness of training, or can we do effective training, and how do we do this more in our systems of healthcare? And then finally, you know, whereabouts can people go for such training? So I might throw that to you, Peter, because that's probably what you've been spending much of your life in the last 3 years.
Yeah, it is indeed. So look, the first thing is there's two real levels, I would say. One is what you can learn in your busy clinical environments. And there's a couple of ways to do that. Unfortunately, we know unless you have some of the shared language, you can't actually work out why Genni or Alex or you, Jen, are such effective communicators. They just get the global picture. So you need to develop a shared language if they're watching you to learn from your role modeling. There's other things you can do to maximize your role modeling as you're in outpatients or doing ward rounds or whatever it is. In other words, then to learn from how you have those conversations. So that's the first bit. I would suggest that there's lots and lots of opportunity. And I think the second thing I would say is if each of us once a week made healthcare communication part of our discussion with our clinical team on how important it is, that sends a really strong message about that is just an important skill, just like pharmacology or any other procedural skill. And secondly, is the evidence is very clear that you need a place to practice, if you like, a simulation or experiential way of doing it. The good news is even something like a half day or a day, you will actually change people's behavior for 6 months, a year. So it's not actually a particularly big investment to have such a big return on something you do all day, every day. So that's probably the kind of core of it, that you need to practice it and you need to maximize those opportunities when you're sitting in with colleagues, but don't make it implicit or assume that they can understand the skills that you've got. You actually have to make them explicit. So I'll stop there.
Thank you. And I think we've pretty much reached the end of our time today. There's been lots of questions that we haven't been able to attend to, for which I apologise, and yet it's been such a rich sharing of knowledge, so thank you. So if anyone in the audience didn't have their questions answered, you could please consider joining the VCCN network, and we can funnel the questions through and endeavour to respond as best we can and point you to resources in the best way that we can. So it brings us to the end of today's Monday Lunch Live special, and I really wish to thank everyone for being involved, particularly Linda, Peter, Genni and Alex, a terrific participation, and thank you for managing all the technology and for practicing and all the things we had to do. I want to thank the VCCC team for keeping us all online, and also thank you to you, the audience, for joining us, and we hope that you will come to subsequent presentations, the Monday Lunch Live, in the future. Thank you.